Welcome back. Hero, good to see you.
See you again.
So I think we're going to get started. But before that, I just wanted to remind everyone that if you did visit the exhibitor booths and you went to 5 or more of our exhibitors, please remember to log in to submit your name for the raffle so you can win the gift cards. So once you've done that, we can now get going with our last session. Dr. Ihara and I will be helping this last session and coordinate the next few video cases. So we're going to start with Dr. Shah, Dr. Raj Shah, who's professor of medicine and a good friend and colleague at the University of Colorado. He's going to be talking about cholangiopancreatoscopy guided laser stricturoplasty. The name itself is so long that Raj needs to simplify it for us by showing us the video technique of doing that.
Thank you, Mahir. Let me start. Appreciate your invitation, and the course is going great. So, okay, so I will need to stay kind of in presenter view, but mostly to show these videos. So basically, the idea here is to talk about what we do with ERCP and cholangiopancreatoscopy for these recalcitrant strictures in the pancreas duct and in the bile duct, and how we can try and preserve organs, really. That's what we're trying to do. I think with interventional endoscopy in general, and the session today is a good example of how we're just progressing more and more toward preserving organs all the way from esophagus to rectum with a variety of techniques that are endoscopically based. And so this is just a small contribution to that. The first video is, I'd like to acknowledge my co-authors on this. This has been submitted for publication, or will be soon, actually. Paul Leonore is currently a faculty at Loma Linda University. Angelina Miley is one of our research coordinators. Abdullah is our current advanced endoscopy fellow. And so I will kind of breeze through some of this for interest of time and show you the case. So this is a 52-year-old with a history of recurrent benign common hepatic duct stricture of unclear etiology for the past 4 years. So quite a long time, has had multiple ERCPs, including multiple evaluations for malignancy, had plastic stenting, metal stenting, all of that to no avail. He really wanted to avoid any type of surgical bypass. And even with a stent-free trial, he then developed recurrent biliary obstruction. And so this is real. This is not sort of a benign stricture that is not symptomatic. This is a real thing. So this is the stricture when we were first looking at it. And you can see a fairly decent, more than 50% of the lumen, in my opinion, is occluded. And on this cholangiogram picture. And then this is the cholangioscopy, digital cholangioscopy image with a guide wire through a very benign appearing stricture. What makes this benign? Yes.
We're not seeing anything other than a blank slide, unless.
Okay. Thank you for telling me that.
Thank you.
Let's see here. How about now?
You can see it.
Yep.
I apologize for that. So luckily that was just the history. So now let me show you the video. I should have gone to the testing session. Okay, so this is the cholangioscopy. And the reason this looks benign is that you can see concentric, it's a concentric stenosis. The vasculature shows thin vessels. They're non-dilated, very benign looking stenosis for those of you that do cholangioscopy. So, or are new to the area. So this is, that's normal appearing mucosa up there. This is the stenosis, and this is a 272 micrometer laser fiber. In this case, we're using thulium laser, which gives a little more continuous pulses. Or sorry, it is a continuous laser, it's non-pulsed. And so that's better for soft tissue dissection. And what you're trying to achieve, you see a little prominent vasculature, but again, it's not branching, dilated vessels, does not look like tumor vessels. And you're really trying to get about a 3-quadrant dissection. And in this case, you know, sometimes that upper aspect of the duct is a little more difficult to treat. There is a way to do it. I may be showing it here. You're trying to go from distal to from proximal to distal, upstream to downstream, and really achieving a combination of both cautery with the laser, and then once the laser treatment is done, then to do balloon dilation to kind of follow up that laser treatment. And that's been the technique that we've been utilized for a few years now in difficult to treat or difficult to resolve biliary strictures, as well as some pancreatic strictures, which I'll show you in a moment. So we finish. That's actually one of the first sessions that we do, followed by balloon dilation. And you can see some improvement, pretty good immediate improvement in the bile duct. Unfortunately, he doesn't tolerate multiple stents. So we had to bring him back. And unfortunately, you see that the stricture has improved some from baseline, but not where we want to be. So this is additional laser treatment. And you can see the stricture, it's almost like we weren't there. And so we did additional laser treatment in this case. And you can see additional treatment here, which I'm going to scan through. And you can see toward the end here, we're getting kind of a clover, like a 4-leaf clover type of effect. And really the movements here are quite not dependent on not just the cholangioscope tip deflection, but you're also moving the duodenoscope to try and get all quadrants that you can treat adequately. And so ultimately he underwent 3 of these sessions. That was a follow-up after the second. And I'll minimize that to show you that after the third cholangioscopy guided laser stricturoplasty, you can see actually up here pretty much resolution of the stenosis. We did leave stents in, and then longer term follow-up is necessary. I do have another video on pancreatoscopy guided treatment, but I don't know if there are any questions prior to that, or if I should just go proceed with the pancreatoscopy one, which I'll make quicker. Just go ahead.
Go ahead.
Okay. And so this is the second one. Let's see here. Can you see this pancreatoscopy guided laser dissection slide?
Yes, we can.
Okay, Emily Yannicka is currently an advanced fellow at Virginia Mason and was instrumental, pretty much did this whole thing really, this whole presentation. But 74-year-old with chronic calcific pancreatitis related to alcohol, tobacco, and had a very difficult stone. You can see on the CT scan here, large pancreatic duct stone obstructing. And then you'll see a pancreatogram that shows the stone and the duct downstream, nothing above it. So similar technique, we go in, we put a stent in first because it was just difficult to access with a pancreatoscope. And then this is the benign stricture in the pancreatic duct that we then do laser treatment for. And I won't belabor the point other than to still try to get 3 quadrants of laser dissection here. You can see the stricture opening up. And then you might ask, well, why not just balloon dilate it? Well, we couldn't even get a wire across this to even get a balloon across it. And as you know, for those of you that do ERCP, you got to be able to get a wire across the stenosis in order to dilate it. So in this case, we couldn't even do that. So we're moving forward here. And there it is. And then you can see a small collection there, look like a small pseudocyst. We were able to actually, after the stricturoplasty, we could break up the stone partly and actually see the pancreatic duct in the tail. And so subsequently, we do a second pancreatoscopy guided session, which I'll let the video play for a moment, and do additional breaking up of the stone upstream of that stenosis, upstream of that area of complete obstruction to allow for breaking up and clearance of that part of the duct. And you will be able to see here nicely demonstrated how there's complete occlusion, no visualization of the tail, After 2 sessions, you can see breaking up of the stone with, that's about half the pancreatic duct that potentially would have become atrophic or gone resection. If they did a tail resection, it would have gone to the extended tail resection more than likely, and risk of diabetes and so forth. So I truly believe this is a pancreas preserving type of intervention that we can offer in these patients. And so I just want to conclude by showing you, let me share the screen again, that, well, quick quote here, I think is very appropriate to APIE maybe, here if I may. Each new observation, each morsel of data wields a two-edged sword. It enables cosmology to thrive on the kind of foundation that so much of the rest of science enjoys, but it also constrains theories that people thought up when there wasn't enough data to say whether they were right or wrong. No science achieves maturity without it. And certainly cholangiopancreatoscopy guided laser dissection is just in its infancy, but I hope that it'll become a wave of the future. I just want to put a plug for our RMIE course with a virtual in February, and then the face-to-face in September. Thank you very much.
Thank you, Raj. That was wonderful. So while we're waiting for any questions from the audience, I just had a question. Do you have a sense of whether there's a higher risk of pancreatitis when you do pancreatic stricturoplasty with the laser as opposed to just doing balloon dilations and stenting and the standard treatments?
We follow each laser stricturoplasty with stenting to follow. So I have actually not seen any higher risk of pancreatitis post-procedure. The risk in our publication of pancreatoscopy over 11-year experience, which is the first 11 years of us doing it, was about 10%. I think it's actually probably lower now, but I don't see it being higher. I have seen one case in which a stricture actually got significantly worse following laser stricturoplasty. And it may be because of circumferential treatment. Maybe the stenting was not long enough of a duration. And so it still remains to be seen. I think largely and through a small series, we're seeing improvement in majority of stenoses, but I did have one case in which things actually got worse after maybe it's a thermal effect within the duct.
I have a quick question, Dr. Shah. Those are very great cases. So I have a friend who has been trying to use the laser technology for resection, like ESD or EMR. And then he said there's some concern for the hemostasis capability. So is there any issue with the hemostatic capability? And also, do you have any control on the depths of the energy? Like 2 millimeter or 3 millimeter? Do you have any idea how deep it goes?
Yeah, thank you for that question. I think that bleeding has not been an issue, at least within the pancreatic duct and the bile duct. There is a coagulation that follows the dissection. The thinner probes, the 200 micrometer probe, will give you a little bit less width and a little bit less depth. But the depth is mostly, and depth and width is also configured based on the wattage, the power that you're delivering. So you can minimize that amount of wattage to get more superficial. And then to get deeper into the, say, 2 millimeter range, you can increase the wattage. And then it'll go up 200, 270 or so micrometer and 350 micrometer. With the 350, you'll get a wider depth, or sorry, a wider area of treatment as well as a deeper depth as you power up the joules.
Thank you.
Raj, can I say something?
Yeah, absolutely.
Just a big congratulations. I think this is really very significant because you've shifted two paradigms at the same time, as you know. One is the paradigm that the bile duct and the pancreatic duct should be looked at just as another GI lumen that we should enter into with the scope and light and do things other than just put contrast like the barium enema equivalent in GI. And the other paradigm that you're shifting over is what we're learning in the esophagus and other places where difficult strictures are managed well with stricturoplasty and incisional therapy versus balloon dilation. So you've shifted two paradigms at the same time. Congratulations.
Thank you very much, Ken. It's really kind of you. Hopefully it gets somewhere.
Thanks, Raj. Thanks for sharing this with all of us.